Chapter 6, Fenn, pages 79 to 86, theme Understanding Mandibular Position Before Learning How to Record It. Open quote. Residency objective. By the end of this section, you should understand why jaw relations exist, the biologic basis of each mandibular position, why complete denture patients are fundamentally different from dentate patients, and how this dictates every subsequent clinical procedure. Close quote. Number 1. The big picture. Why jaw relation records exist. Before a patient becomes a dentulous, nature determines the mandibular position through 4 major determinants. 1. Teeth, occlusal guidance. 2. TMJ, condylar guidance. 3. Muscles. 4. Neuromuscular control. Once all teeth are lost, one determinant disappears completely. The prosthodontist must recreate a functional jaw relationship without the natural occlusion. That is the purpose of jaw relation records. Clinical philosophy. Jaw relation records are not simply measuring the patient's bite. They are an attempt to reproduce a mandibular position that is repeatable, physiologically acceptable, comfortable, stable, compatible with the TMJ, compatible with muscles, compatible with the planned denture. This is why jaw relation recording is the foundation of complete denture success. Number 2. Maxillomandibular relationships. Fenn describes 3 fundamental mandibular relationships. They are not interchangeable. Each answers a different biological question. A. Retruded position. Retruded contact position, RCP, biological concept. This is a joint position, not a tooth position, not a muscular position. It describes where the condyles sit inside the glenoid fossae. Fenn's definition. Mandible is retruded, condylar heads lie posteriorly in the glenoid fossae. Modern prosthodontic interpretation. Today, we generally discuss this under centric relation CR. Modern CR is not exactly identical to Fenn's description. Historically, older prosthodontic literature described CR as, open quote, most posterior position, close quote. Modern GPT definitions describe CR as, open quote, an anterosuperior musculoskeletally stable position independent of tooth contact, close quote. This evolution occurred because research showed the condyle should not necessarily be forced into the extreme posterior position, as that may strain retrodiscal tissues. Residency Pearl. If an examiner asks, open quote, is Fenn's RCP identical to modern CR? Close quote. Correct answer, no. Fenn reflects the historical concept of a posterior condylar position, whereas modern prosthodontics emphasizes a musculoskeletally stable condylar position rather than the most posterior one. Why is RCP so important? In an edentulous patient, there is no intercuspation. Therefore, we need a reproducible mandibular reference, a mandibular position that can be repeated every appointment. That reproducible reference becomes centric relation retruded contact position. Everything else depends on it. Mounting casts, establishing vertical dimension, tooth arrangement, balanced occlusion, denture stability. If this record is inaccurate, everything constructed afterward becomes inaccurate. Have clinical characteristics. Ideal CR should be repeatable, comfortable, independent of teeth, stable, reproducible, physiologic. Common misconception. Residents often think, open quote, condyles are posterior because muscles pull them backward. Close quote, not exactly. They become seated because of joint anatomy, ligament guidance, coordinated muscle activity. The TMJ anatomy determines the position, not simply muscle contraction. Have clinical importance. CR is used because it is repeatable. Maximum intercuspation cannot be used in complete dentures because there are no natural teeth. 3. Rest position. Physiologic rest position. This is probably the most misunderstood concept in complete denture prosthodontics. Biological definition. Rest position is the habitual position assumed by the mandible when patient is upright, relaxed, not chewing, not swallowing, not speaking. There is minimal tonic muscular activity. Important point. This is not centric relation. The mandible is literally hanging under the influence of muscle tone, gravity, neuromuscular reflexes. Rest position is not constant. One of the biggest residency concepts. Many undergraduate books suggest rest position is constant. Modern literature disagrees. It is variable. It changes with posture, emotional stress, fatigue, age, pain, respiration, tongue posture, head position, neurologic disorders, medications, dentures, time of day, exactly as Fenn begins to mention. Residency Pearl never established vertical dimension using only rest position. Modern prosthodontics recommends combining physiologic rest, phonetics, aesthetics, facial appearance, swallowing, patient's comfort, closest speaking space, previous records, when available. This is another concept frequently misunderstood. Definition. Difference between vertical dimension at rest, VDR, and vertical dimension of occlusion, VDO, normally approximately 2 to 4 millimeters. Why does this space exist? Because elevator muscles maintain slight tonic contraction, but teeth are not supposed to contact continuously. Continuous tooth contact would produce muscle fatigue, periodontal overload, TMJ overload. Therefore, nature maintains a physiologic clearance. Clinical importance. If freeway space disappears, muscles become overactive, patient becomes uncomfortable. TMJ symptoms, denture instability. Functional relation. Now we move from static positions to dynamic movement. Definition, relationship of maxilla and mandible during movement. Unlike CR, functional relation changes continuously. It includes protrusion, lateral movement, mastication, speech. Biological control movement is determined by posterior determinants. TMJ, anterior determinants, teeth. Muscles coordinate both. In dentate patients, movement is guided by canine guidance, incisal guidance, cuspal inclines. In complete denture patients, these natural guides disappear. The prosthodontist must recreate them. The edentulous state. This section is one of the most important in Fenn. Why? Because it explains why complete dentures are fundamentally different from natural dentition. Once teeth are extracted, the patient loses 1. Occlusal guidance, gone. Incisal guidance, gone. 3. Cuspal guidance, gone. 4. Proprioception from periodontal ligament, gone. Only one determinant remains, the TMJ. Therefore, complete denture treatment depends much more heavily on muscles, joints, polished surfaces, neuromuscular adaptation than fixed prosthodontics. Clinical consequences. Loss of teeth means reduced mandibular guidance, altered chewing pattern, reduced masticatory efficiency, altered muscle coordination, progressive ridge resorption, reduced stability. Residency concept. This explains why complete dentures never completely reproduce natural teeth. The patient is learning an entirely new neuromuscular system. Articulators, introduced by Fenn. Fenn introduces 2 broad categories. 1. Plain line mean value articulator records only hinge movement, requires only CR record. Advantages, simple, cheap, fast. Disadvantages, cannot reproduce, lateral movements, protrusion, individual condylar paths. 2. Adjustable, semi-adjustable articulator records, individual condylar movements, requires additional jaw relation records. Advantages, more accurate, better tooth arrangement, improved occlusion, closer simulation of patient movement. Residency pearl. Remember, the articulator determines what records are required. More sophisticated articulators require more sophisticated records. Clinical summary. Think of the chapter as answering 3 questions. Question 1. Where is the mandible? Rest position. Question 2. Where should dentures be constructed? Centric relation, RCPR. Question 3. How does the mandible move? Functional relation. High-yield viva points. Jaw relation records reproduce mandibular position in an edentulous patient. RCP in Fenn is a historical concept and differs from the modern GPT definition of CR. Rest position is a physiologic, variable position, not a fixed reference. Freeway space equals VDR minus VDO, normally about 2 to 4 millimeters. Functional relation refers to mandibular movements during function. Loss of teeth eliminates occlusal, incisal, and cuspal guidance, but preserves TMJ guidance. Mean value articulators require only CR. Semi-adjustable articulators require additional eccentric records. End of response 1. Response 2 will cover the clinical procedures, record blocks and base plates, trimming the upper record block, labial fullness, occlusal rim height, anterior and anteroposterior planes, posterior palatal border, vertical dimension, freeway space assessment, and the consequences of incorrect vertical dimension, the core of complete denture jaw relation procedures. Jaw relation records, response 2 of 3, residency mastery. Chapter 6, Fenn, pages 83 to 92. Theme, how the prosthodontist establishes a biologically acceptable vertical dimension and occlusal plane. Open quote, residency objective. Understand why every millimeter of the occlusion rim matters, how vertical dimension is established, why posterior palatal seal, PPS, is critical, and how these procedures affect denture function, stability, aesthetics, speech, and patient adaptation. Close quote. Number 1. Record block. The diagnostic prototype. Common undergraduate mistake is to think, open quote, record block is just wax. Close quote. No. A record block is a diagnostic instrument. It temporarily replaces the future denture. It allows the clinician to determine vertical dimension, occlusal plane, lip support, tooth position, midline, smile line, canine line, jaw relation. Think of it as the prototype of the complete denture. Components. 1. Base plate represents the denture base, must fit exactly like the future denture. 2. Occlusion rim represents future teeth. Its position determines tooth position, facial support, speech, vertical dimension. Clinical principle. If the record base rocks, everything recorded becomes unreliable. This explains why experienced prosthodontists spend so much time perfecting the record base before recording CR. Number 2. Base plates. Fenn discusses different materials. Instead of memorizing them, understand their purpose. The ideal record base should be accurate, stable, rigid, retentive, non-distorting, easy to modify. Wax base plate advantages. Cheap, fast, easy to fabricate. Problems. Softens at body temperature. Distorts easily. Moves during jaw relation recording. Clinical implication. Avoid for definitive jaw relation whenever greater accuracy is required. Thermoplastic base plate improvement over wax. Advantages. More rigid, better dimensional stability, better intraoral accuracy. Cold cure acrylic base. This is the clinical standard in many teaching institutions. Advantages, excellent fit, minimal distortion, rigid, stable, easy to adjust. Metal base, gold standard for stability. Advantages, excellent adaptation, very rigid, heat resistant, minimal distortion. Disadvantages, expensive, time-consuming, technique-sensitive. The more stable the base, the more accurate the jaw relation. Most jaw relation errors are actually record base errors, not patient errors. Occlusion rim. The occlusion rim is not the denture tooth. It is simply a substitute for future teeth. Its functions are much broader than many students realize. Functions. Determine vertical dimension, lip support, occlusal plane, tooth position, midline, smile line, canine position, phonetics, facial aesthetics. Occlusion rim materials Fenn describes: wax, most common, easy to manipulate, poor dimensional stability, impression compound, more stable, less distortion, useful for jaw relation. Plaster abrasive rim, rare today, historically used for functional generated path techniques. Residency pearl. Modern prosthodontics overwhelmingly favors wax rims on rigid acrylic record bases because they provide a good balance between stability and ease of modification. Trimming the upper occlusion rim. This is probably the most clinically important procedure in early complete denture treatment. Every millimeter matters. Hey. Labial fullness question. Why does the upper rim project labially? Answer: to replace lost alveolar bone and tooth support. Without teeth, the upper lip collapses. The wax rim restores facial support. Too thick results: protrusive upper lip, artificial appearance, difficulty closing lips, increased muscular strain. Too thin results: sunken lip, aged appearance, reduced vermilion display, poor facial profile. Clinical goal: natural lip support, not maximum lip support. B. Height of upper occlusion rim, one of the highest yield topics. The rim determines future incisal edge position. Clinical assessment: relaxed lips. Patient sitting upright. Upper central incisors should show approximately 2 to 3 millimeters below the relaxed upper lip. Fenn uses a proper incisor display. Older patients, less display. Loss of muscle tone, upper lip length increases. Residency concept. Incisal display is determined by lip length, age, gender, facial form, muscle tone, not by a fixed number alone. Anterior occlusal plane, viewed from the front, should be parallel to interpupillary line. Why? If not, the patient appears to have crooked teeth even when every tooth is perfectly arranged. D. Anteroposterior occlusal plane viewed from the side, should be parallel to Camper's line, allotragus line. Why? because this orientation provides better aesthetics, better function, better stability, more favorable occlusal forces. Clinical Pearl Camper's line is a guide, not an absolute rule. Different patients may require slight modification based on aesthetics, ridge anatomy, and neuromuscular factors. Number 5, posterior palatal seal, PPS, one of the most misunderstood areas in complete dentures. Definition: posterior extension of the maxillary denture into the compressible soft palate. Purpose: to create a peripheral seal that improves retention. Biological basis: soft palate tissue is compressible. When the denture compresses it slightly, air cannot enter beneath the denture. Negative pressure develops. Retention improves. HAG PPS functions: improves retention, compensates polymerization shrinkage, maintains border seal, prevents food accumulation, improves patient comfort, reduces gagging caused by poor seal, reduces air leakage during speech. Vibrating line definition: junction between movable and immovable soft palate. Clinical method: ask patient to say ah. The moving tissue identifies the vibrating line. Important residency point: the vibrating line is not identical in every patient. It varies with soft palate form, phonation, technique, head posture. Fovea palatinae: 2 small pits near the midline. Clinical importance: useful landmark, but not the posterior border of the denture. Many undergraduate students incorrectly use them as the PPS border. Consequences of incorrect PPS: underextended, poor retention, air leakage, loose overextended, pain, ulceration, gagging, speech problems, dislodgement during swallowing. Number 6, vertical dimension, VDO. This is the most important concept in complete denture prosthodontics. Definition: vertical relationship between maxilla and mandible, measured between 2 selected facial points. 2 dimensions exist: vertical dimension at rest, VDR, physiologic position; vertical dimension of occlusion, VDO, teeth or rims are in contact. Formula freeway space equals VDR minus VD to 4 millimeters. Normal? Why multiple methods are used? No single method accurately determines VDO. Therefore, combine rest position, facial appearance, aesthetics, phonetics. S sounds closest speaking space. Swallowing, previous dentures, pre-extraction records, patient comfort. This is the modern prosthodontic approach. Consequences of increased VDO biomechanics: muscles cannot relax, continuous elevator muscle contraction, fatigue, pain, instability. Clinical features: clicking teeth, difficulty swallowing, lip incompetence, TMJ discomfort, long facial appearance, muscle fatigue, sore ridges. Consequences of decreased VDO biomechanics: mandible rotates excessively upward, overclosure, reduced lower facial height. Clinical features: wrinkled appearance, deep nasolabial folds, angular cheilitis, cheek biting, reduced masticatory efficiency, loss of facial support, pseudoprognathic appearance. Angular cheilitis: why does it occur? Overclosure, corners of mouth fold inward, saliva accumulates, candida and bacteria proliferate, inflammation develops. Clinical summary: everything in this response is centered around one objective. Open quote. Create a stable record base, position the rims correctly, establish a biologically acceptable VDO, and obtain proper lip support and occlusal plane before recording centric relation. Close quote. If these steps are incorrect, even a perfectly recorded centric relation cannot produce a successful denture. Residency Viva Pearls: record base stability determines jaw relation accuracy. Occlusion rim is a diagnostic tool, not merely wax. Upper incisal display is evaluated dynamically with facial aesthetics, not by numbers alone. Camper's line and interpupillary line are guides, not absolute laws. PPS should compress displaceable tissue slightly, not extend beyond the vibrating line. Fovea palatinae are landmarks, not the posterior denture border. VDO should never be determined by a single method. Increased VDO overloads muscles. Decreased VDO leads to overclosure and facial collapse. End of response 2 of 3. Response 3 will cover the most advanced part of the chapter: recording centric relation, RCP. Jaw relation records, response 3 of 3. Chapter 6 Fenn, pages 93 to 99. Theme: recording centric relation, CR, the heart of complete denture prosthodontics. Open quote, residency objective. By the end of this session, you should understand how centric relation is recorded, why it is difficult, how to verify it, why records fail, and how modern prosthodontics approaches CR compared with traditional techniques. Close quote. Number 1. Why is recording-centric relation so difficult? This is one of the first questions asked in Residency Viva. The answer is simple: because the patient has no teeth. In a dentate patient, teeth guide closure. Proprioception from the periodontal ligament helps locate habitual occlusion. In an edentulous patient, no teeth, no periodontal proprioception. Occlusion rims can move. Mandible is guided only by muscles and TMJ. Therefore, the prosthodontist must guide the patient into a repeatable mandibular position. Number 2. What is centric relation? Modern understanding. GPT definition. Centric relation, CR, is a maxillomandibular relationship in which the condyles articulate in an anterosuperior position against the posterior slopes of the articular eminences, with the disc properly interposed. Key characteristics: independent of tooth contact, repeatable, reproducible, physiologic, stable, musculoskeletally determined. Residency Pearl. Never say, open quote, CR is where the teeth meet. Close quote. That is centric occlusion, CO, or maximum intercuspation, MI, in dentate patients. CR is a joint relationship, not a tooth relationship. Number 3. Clinical requirements. Before recording CR, a CR record is only as good as the conditions under which it is made. Before recording, ensure stable record bases, correct vertical dimension, VDO, even occlusal rim contact, no rocking, relaxed patient, comfortable upright posture, no premature contacts. If any of these are missing, the CR record is unreliable. Number 4. Methods of guiding the mandible into CR. Fenn describes several methods. Modern prosthodontists often combine them. A. Relaxation method. Principle: relaxed elevator muscles allow the mandible to assume a reproducible position. Technique: seat patient upright. Ask them to relax. Lightly guide the mandible. Close gently. Advantages: physiologic, comfortable, widely used. Limitation: works poorly in anxious or neuromuscularly unstable patients. B. Swallowing method. Principle: during swallowing, the mandible naturally returns towards CR. Technique: ask patient to swallow. Immediately close onto the rims. Advantages: simple, natural movement. Limitation: not reliable in every patient. C. Fatigue method. Principle: repeated protrusive movements fatigue the lateral pterygoid muscles. Once fatigued, the mandible tends to return to CR. Clinical use: useful in patients with habitual protrusive closure. D. Chin point guidance, bimanual guidance. This is the technique most associated with Dawson. Principle: the operator gently guides the mandible without forcing it. Clinical Pearl: forceful posterior pressure is wrong. The goal is to guide, not push. Excessive pressure can displace the condyles and distort the record. Number 5. Gothic arch tracing. One of the highest yield residency topics. Definition: a method of recording mandibular movements using a stylus and tracing plate. As the patient performs protrusive and lateral movements, the stylus creates an arrowhead Gothic arch. Principle: every mandibular movement begins from the same reproducible position. The intersection of right lateral movement, left lateral movement, protrusive movement creates the apex. The apex represents centric relation. Types: intraoral tracing, stylus inside the mouth, less visible, less bulky, more commonly used. Extraoral tracing, stylus projects outside the mouth, easier to visualize, more cumbersome. Interpretation of the tracing: sharp apex, excellent neuromuscular control, reliable CR. Rounded apex suggests poor muscle coordination, mandible not returning consistently, possible unstable record base. Double apex suggests two habitual closure paths, TMJ dysfunction, operator error, patient inconsistency. Irregular tracing possible causes: loose record bases, patient movement, incorrect VDO, pain, poor cooperation. Residency question: why is Gothic arch tracing considered more scientific? Because it records mandibular movement dynamically rather than relying solely on the operator's manipulation. Number 6. Verification of centric relation. Recording CR once is not enough. It must be verified. Verification methods: repeat the record several times. Check reproducibility. Use Gothic arch tracing. Remount if discrepancies exist. A reproducible CR is more important than a single perfect-looking record. Number 7. Sealing the jaw relation record. Once CR is obtained, The upper and lower rims must be locked together. Methods: heated wax, wax wafer, plaster, zinc oxide eugenol paste in some protocols, silicone registration materials, modern practice. Modern perspective. Today, elastomeric bite register materials provide better dimensional stability, less distortion, greater accuracy than wax. 8. Common errors in jaw relation records. Every resident should know these. Error 1. Unstable record base. Most common cause of inaccurate CR. Always check stability first. Error 2. Incorrect VDO. If VDO is wrong, CR recording will also be wrong. Error 3. Premature rim contact. One side contacts first. Mandible deviates. False CR is recorded. Error 4. Excessive operator force. Never push the mandible posteriorly. Guide gently. Error 5. Patient anxiety. Muscle guarding prevents true CR. Allow the patient to relax before recording. Error 6. Poor wax adaptation. Wax distortion alters the record during removal. Number 9. Modern evidence-based perspective. Historically, many techniques aim to force the condyles into the most posterior position. Modern evidence favors a musculoskeletally stable CR, minimal operator force, repeatability over forceful retrusion, multiple verification methods. The emphasis has shifted from finding the most posterior position to finding the most stable, reproducible position. Number 10. Clinical workflow residency level. A successful jaw relation appointment follows this sequence. 1. Verify record-based stability. 2. Verify occlusion rim adaptation. 3. Establish correct VDO. 4. Confirm lip support and occlusal plane. 5. Guide the patient into CR. 6. Record CR. 7. Repeat and verify. 8. Mount casts on the articulator. 9. Proceed to tooth arrangement. Skipping or rushing any step compromises the final denture. High-yield residency Viva questions. 1. Define centric relation according to GPT. 2. Why is CR independent of tooth contact? 3. Why is CR preferred in complete dentures? 4. Why is CR difficult to record in edentulous patients? 5. What are the prerequisites for recording CR? 6. Compare the relaxation, swallowing, fatigue, and chin point guidance methods. 7. Describe Dawson's bimanual manipulation. 8. What is Gothic arch tracing? 9. Differentiate intraoral and extraoral tracers. 10. What does the apex represent? 11. Causes of a rounded or double apex. 12. How do you verify CR? 13. What are the common causes of CR errors? 14. Why are elastomeric registration materials preferred over wax? 15. How has the definition of CR evolved in modern prosthodontics? Have our ultimate clinical pearls, CR is a joint position, not a tooth position. Never force the mandible into CR, guide it gently. Repeatability is more important than a single record. An unstable record base is the commonest source of error. Correct VDO must be established before CR. A sharp Gothic arch apex indicates a reliable CR. Modern prosthodontics favors a musculoskeletally stable condylar position rather than the historically described most posterior position. Final residency take-home message. Think of complete denture-jaw relation as building a house. Record base equals foundation. Vertical dimension, VDO, equals height of the building. Centric relation, CR, central pillar. Occlusal plane equals floor alignment. Tooth arrangement equals interior finishing. If the foundation record base or the central pillar CR is inaccurate, no amount of occlusal adjustment later will produce an ideal denture. This principle is one of the cornerstones of complete denture prosthodontics and is worth carrying